Hello friends, greetings from Global Academy of Medical Education. I am Dr. Vaibhav Seth. After so much of drama, finally on 5th of March we had NEET PG 2023, right? So, first of all, many congratulations to those who have appeared for the exam, and I am here to present before you the recall based analysis of the medicine questions that were asked in today's exam, NEET PG, right? So first of all, a disclaimer and many thankful and many thanks to the students who have helped me in framing the questions that were asked in the exam. And after giving such a hectic exam, they were kind enough to let us know about the questions that were asked in the exam along with the options. So these are not my questions. These are all recall based questions that I have collected from various sources. So there might be some discrepancy in the language of the questions and in the options that you might have got in the exam. So in case of any discrepancy or in case of any doubts, please feel free to contact me and write in the comment box, and you can let me know that these were the options or these are not the options, or you had certain extra options, or maybe certain options that I have got were not asked in the exam. So any sort of permutation and combination could be possible. You can let me know. So without wasting further time, I'll start with the analysis of the paper and the questions that were asked in the exam. So there were a lot of questions from the neurology portions. There were a lot of questions. If you have gone through the recall that I have made in the FMG, in FMG also there was a change in the pattern. There were a lot of questions from the neurology per se, right? So you have this question where you have an encephalitis and you have a bilateral temporal hemorrhagic involvement, and you are asked about the causative agent. So first, what you have to know from this question is they are asking you about encephalitis. They are asking you about encephalitis. Along with that, they are mentioning that there is a bilateral temporal involvement and there is hemorrhagic involvement. So bilateral temporal hemorrhagic involvement goes in the favor of herpes encephalitis, goes in the favor of encephalitis caused by HSV, right? It goes in the favor of encephalitis that is caused by HSV. Now, what you need to remember is along with the temporal involvement, there can be involvement of the frontal lobe and the insular cortex Most often, the involvement can be asymmetrical. Now, they have not mentioned in the question whether the involvement is asymmetrical or symmetrical, but a question of encephalitis with bilateral temporal hemorrhagic involvement. And the third important point is hemorrhagic changes in the MRI. So all these features are seen in herpes simplex encephalitis, HSV encephalitis. Now suppose in the same question, if you had two options, one in the form of HSV and the other in the form of autoimmune encephalitis, and the hemorrhagic component was not mentioned, your answer would have changed to autoimmune encephalitis. But for this question, encephalitis with bilateral temporal hemorrhagic involvement, your answer would be HSV, right? Next question. You have a patient who is having difficulty in expressing the emotions. So that means first point you are getting is a expressionless facies. Along with that, patient is having rigidity and tremors. So all these three features are classically seen in Parkinson's disease, and the area that is responsible for the pathophysiology of Parkinson's disease, if you have to localize what area is abnormal in Parkinson's disease, your answer would be Basal ganglia. Your answer would be basal ganglia, right? Because we have read that there is loss of nigrostriatal dopaminergic neurons in PD. In PD. So expressionless facies, rigidity and tremors going in favor of Parkinson's disease, and your localization would be basal ganglia. Next question, this is a very common question and an important repeat that is always asked in exam. So you have an alcoholic patient and you have an acute onset of ataxia. You have an acute onset of ataxia and the patient is having nystagmus. So you have to remember that this is basically Wernicke's encephalopathy. This is basically Wernicke's encephalopathy, and you all know the triad of Wernicke's encephalopathy where you have global confusion, ophthalmoplegia, and ataxia. Right? So acute onset ataxia in an alcoholic patient with these features goes in favor of Wernicke's encephalopathy, and treatment that we offer in such cases is IV thiamine. Right? Next question was, you have a patient with subarachnoid hemorrhage. The BP is given is 160 by 110. Now they are asking you what is the next best step in management, right? Next best step in management. So if we analyze the options that they have given here, you are not giving mannitol because the ICP is not raised. You are not going for any surgical therapy because you don't know the cause of subarachnoid hemorrhage. They have not mentioned whether it is traumatic or non-traumatic. So we actually don't know what is the cause of subarachnoid hemorrhage. Plus, they have not mentioned in the question anything about the sensorium or anything about the complications that would help us to decide whether we are going in a favor of urgent surgical treatment or not. What is written here is, so you will have confusion between the two options, and that is nimodipine and the angiography. We do angiography, or you can say digital subtraction angiography, to decide the cause of aneurysm, and to find whether you have any ruptured aneurysm or not, and that can also help us in the management. You can do the coiling. But they are asking here is next best step in management. So before proceeding with the angiography and to find out the cause, you have to first prevent the important complication of subarachnoid hemorrhage, which is the vasospasm. You have to prevent this important complication, and that is vasospasm. So remember, we use this drug that is known as the nimodipine. Which is a calcium channel blocker. The function of basically nimodipine is to prevent the vasospasm. So your correct answer here would be nimodipine. And I think many of you would have a confusion between angiography or nimodipine, but answer here would be nimodipine. Okay. Next is, you have been asked a question that you have to calculate GCS in a patient who has eye opening to pain, who has saying inappropriate words, and who is withdrawing to pain. So let's see how we look for the GCS and what is the scoring system that we employ. So GCS has got three components. One is the eye response, second is the verbal, and third is the motor response. And the total score is somewhere around 15. Right? The total score is 15. So you are asked in that question that a patient is having eye opening response to pain. So you are having E2. Then you are having a motor response where patient is having withdrawal from pain. where the patient is having withdrawal from pain, so you are having M4. So you are having M4. And in the verbal response, patient is saying inappropriate words. The patient is saying inappropriate words. So this makes it V3. So you are having E2 M4 V3. That will be the answer to your question, right? Next question. You have an X-ray, right? And it is showing a middle lobe consolidation, and it is showing a middle lobe consolidation. As you can see from the X-ray, it is showing a Silhouette sign. It is showing a Silhouette sign with air bronchogram. So I have not received all the 4 options in this question. So let me know what I have missed out. But if this is your X-ray, what you are getting, and you are seeing a air bronchogram, it is clearly visible that you are seeing a air bronchogram with a Silhouette sign, your answer would be pneumonia. You can have confusion with the loculated pleural effusion, but with this X-ray, your answer would be pneumonia and not a loculated pleural effusion. Next question was, you have a 70-year-old man who is having slowing of movements. So slowing of movements, that means Parkinson's, right? And there is staring at sky. Along with that, there were certain other options in the form of visual hallucinations. It was also mentioned in the question that the patient is having visual hallucinations and the patient is also having memory loss. Please mention in the comment box whether this thing was mentioned or not, because your answer would change accordingly. So analyzing all the 4 options that were given, and the most important thing that was given was presence of Lewy bodies in the biopsy. So what you can be sure from this question is that you are being asked about alpha synucleinopathy. There are 2 types of disorders. One is the tauopathy and the other is synucleinopathy. So in this particular question, you are being asked about synucleinopathy. So you have got following points: that you have slowness of movements, you have vacant stare look, you have got visual hallucinations, and you have got memory loss. And in the autopsy, they are saying that you have Lewy bodies. Now, if with all these questions, if you have in your option DLB, then the DLB would be the best answer. But if DLB was not given, then the confusion would arise between PD versus AD. So let me tell you guys that in PD, the dementia and all these components of visual hallucinations and the memory loss, they come very late into the illness, somewhere after 10 years. And that's what we call as a Parkinson's disease dementia. So in this question, basically, they have not mentioned that the disease is so long. So I would consider that if the DLB was in the option, your answer would be DLB. If DLB was not in the option, your answer would be AD. Because AD also has presence of Lewy bodies. And visual hallucinations and the vacant stare look are very common in AD also. And in certain atypical Alzheimer's disease, you can have motor manifestations in the form of myoclonus and Parkinson's. So let me tell you, in this question, the options and the language would basically decide the answer. I have dissected out the concept for you. If the slowing of movements were not mentioned, you will not get the confusion about Parkinson's disease in this question. If DLB is mentioned in the option, please let me know in the comment box whether DLB was mentioned in the exam or not. If it is mentioned, then it is the best answer. If it is not mentioned, then your best answer would be Alzheimer's disease. Because Parkinson's disease, they have not mentioned the term Parkinson's disease dementia, and Parkinson's disease takes a lot of time to develop a dementia. And that is a very rare situation also. That is a very rare situation also, because Parkinson's disease landing up into dementia, it would take somewhere close to 10-15 years. It would take somewhere close to 10-15 years. But you have a presence of Parkinson's and you have a presence of dementia and visual hallucinations that develops within a span of 1 to 2 years of the diagnosis of Parkinson's disease, then that's a red flag sign and it is seen in DLB. And PSP would not be the answer because it is a tauopathy. Because it is a tauopathy, right? It is a tauopathy. Next question, you had an image based question on pansystolic murmur. So what actually is a pansystolic murmur? The murmur starts from S1 and ends at S2. The murmur starts from S1 and ends at S2, right? So what is important to know here, S1 and S2 is systole and S2 and S1 is diastole, right? So a murmur that starts from S1 and ends at S2 is known as a pansystolic murmur, and you guys are very well aware that the causes of pansystolic murmur are mostly three. You have MR, you have tricuspid regurgitation, and you have the ventricular septal defect. So in your options that were given, MR is the best answer here. So moving to the next question, you have another question from the cardiology where you are asked that the patient is having a mid-diastolic murmur. So mid-diastolic murmur causes are MS and tricuspid stenosis. And they are asking you that you are having a prominent A wave in JVP. Normally in MS with presence of AF, you have absent A wave. You have absent A wave in JVP. And in tricuspid stenosis, the pressure in the right atrium shall increase. And that's why you will get a prominent A wave. A wave in JVP. So your answer to this question would be tricuspid stenosis. The answer would be tricuspid stenosis. Next question was, this was your question from endocrine basically. So you have a female patient who's having a midline swelling. So that means you are having a thyroid swelling. And they have also given some of the manifestations that is linking us towards the diagnosis of hyperthyroidism. So a thyroid swelling with tremors and atrial fibrillation is there, and patient is having a comorbidity of asthma. So guys, you should remember that whenever there is a new onset AF, you should always rule out thyrotoxicosis. Right? Now the question that you have been asked is, they are telling you that you are having a midline swelling. So probably our patient is having a thyroid swelling that could be due to Graves or a multinodular goiter. And the presence of tremors in this question, is making us think that the patient is probably having hyperthyroidism. Now, along with hyperthyroidism, this patient is also having atrial fibrillation and the comorbidity is asthma. So now this is basically an integrated pharma and medicine question that is testing your knowledge about the different drugs that can be used in the management of atrial fibrillation in background of thyrotoxicosis and asthma. So when you are having asthma, you know that the beta blockers would go out of the question. So you are left with two options. One is diltiazem and the other is propylthiouracil. So this is a calcium channel blocker and this is an anti-thyroid drug. So basically what they have asked is the next best management. This is the question, that next best management. So if you are asked about next best management, if you give the anti-thyroid drug, it will not control the symptoms of thyrotoxicosis in a very small span of time. It's going to take some time. So in that period of time, you have to control the atrial fibrillation. You have to control the rate of the atrial fibrillation, and that can be achieved by diltiazem. And that can be achieved by diltiazem. Hence, the best answer in this question would be diltiazem. The best answer here would be diltiazem, right? So moving over to the next question. Now this was a image based question where you are asked that you are having a DIC in a background of leukemia, and if this was the image based question asked, you can easily see that you are seeing the presence of air rods. Which is basically responsible for the DIC, and it is seen in the M3 variety of AML. The translocation is 1517, and it carries a good prognosis. Right? So this is basically a repeat and easy question that was asked in your exam, right? Now, next question that was asked, it is also a repeat question. You have a HIV patient and you are having some palatal lesions, Well, this is a classical case of Kaposi sarcoma. It is a classical case of Kaposi sarcoma, right? Next question you were asked is, you have an asthmatic patient who is on inhalers and has developed oral white patches. So this means your patient is developing candidiasis. And you would like to use antifungal drugs in such cases. So your answer would be clotrimazole. Which is basically an azole group of drug that we use as antifungals. Now, to all those patients who are on inhalers, we give them an advice that you should always gargle. After taking an inhaler. This would prevent the development of candidiasis, all the white patches, right? Because the inhalers, they have, along with your long-acting beta agonist in the inhalers, they also have certain inhaled steroids. That can deposit in the oral cavity, and it can give rise to oral candidiasis. So always the advice to the patient should be that you should be gargling after taking the inhalers, right? Next question. This was basically a integrated question with cardiology and your electrolyte imbalance disorder. You are being asked that you have a ECG changes of hyperkalemia. So what are the ECG changes that you know of? We all know that tall T waves can be seen in hyperkalemia. With the severity, the tall T waves can even change into sine wave pattern. So whatever the severity of hyperkalemia would be, the ECG would show that amount of changes. If the potassium level is more than 8, our ECG would show sine wave pattern. And you are asked what is the drug that can predispose the patient to hyperkalemia. So let me tell you that in the option beta blockers and calcium channel blockers, they do not cause hyperkalemia. We have spironolactone as a drug which can predispose to hyperkalemia. Other drugs that are responsible is ACE inhibitors, ARB. All these drugs can cause hyperkalemia. You also have aldosterone antagonists and certain antibiotics like trimethoprim. So all these drugs can cause hyperkalemia, which you should be aware of, right? Next question was, you have a 10-year-old child with a history of resection of the pituitary tumor. There is resection of pituitary tumor, and the patient is having urine osmolarity which is less than 100, and there is hypernatremia. So it's a very clear-cut diagnosis of diabetes insipidus. diabetes insipidus. Now diabetes insipidus can be central and it can be nephrogenic. Right? So what you can get from this question, that you are having a acquired central DI. What you can understand from this question, that there is a acquired central DI. So once the DI that has developed in this patient, which is a central, so you know that it is responsive to the AVP. It is responsive to the AVP that we give from the outside. So your answer would be a lifelong supplementation of the AVP. Your answer here would be lifelong supplementation of AVP in this patient, right? Next question. This is basically a question from rheumatology. So you have a white hands working in the machinery industry and they are asking you what is the cause behind it. So let me tell you that you have a condition known as secondary Raynaud's. You have a condition known as secondary Raynaud's. We have learned in rheumatology that there is something known as primary Raynaud's and there is a secondary Raynaud's. So vibration induced white hands is a type of secondary Raynaud's, and this was basically asked in your exam, that what basically is the causative agent behind the white hand. So your answer is vibration. And this is responsible for secondary Raynaud's. Right? So moving to the next question. So before we move on to the next question, let's just revise this image. A similar question was asked in your FMG examination. It was asked in your FMG examination where they had asked that if the patient is having bitemporal hemianopia, where is the lesion? Now in your NEET PG examination, they asked you that if the patient is having homonymous hemianopia, where is the lesion? So if you know about the anatomy, of the pathway, of the optic pathway, then you must be aware of the fact that you have two fibers, nasal fibers and the temporal fibers that come at the chiasma, and here there is a crossing of the nasal fibers. And the temporal fibers, they go like that only without crossing, right? So here you have the optic nerve, which then becomes the chiasma, and here it forms the optic tract. Which then goes to the lateral geniculate body. There you have the Mayer's loop. Finally, you have the optic radiations that go and converge into the calcarine fissure of the occipital cortex. Now, what is important here is to know is when you have a lesion at optic chiasma, what you get is a bitemporal hemianopia. So here you have the temporal field of vision that is affected. Now, when you have a lesion in the optic tract, what you get is a homonymous hemianopia. But this is contralateral. What you have to remember is this is contralateral. See, if you are having a right homonymous hemianopia, your left optic tract will be affected. So let's now go to the question, what they are asking. So they are asking you that right-sided homonymous hemianopia. There is a right-sided homonymous hemianopia and they're asking you where is the lesion. So if then the option there was no mention about right or left, then the answer is simple as optic tract. But if they are mentioned right or left, then your answer would be left optic tract. So this is an example of a integrated anatomy and medicine question. So basically the authorities have made very clear that the questions that would be asked would be integrated. No direct questions anymore, right? No direct questions. All of these questions are integrated. All of these questions have integrated and they have got clinical implications, right? Next question was, you have a patient with hypercalcemia. You have a patient with hypercalcemia and you have a lung mass. So you guys are aware of the fact that the most common cause of hyperparathyroidism is, most common cause of hypercalcemia is basically hyperparathyroidism. And second most common cause of hyperparathyroidism is humoral calcemia of malignancy. Which basically arises as a part of paraneoplastic manifestation due to synthesis of parathyroid hormone related peptide. So you should know most common malignancy to cause hypercalcemia is lung cancer. Among the types of lung cancer, this is basically a paraneoplastic manifestation. It is the small cell cancer. That causes maximum paraneoplastic manifestations. But here is the exception, and that exception is that squamous cell cancer causes hypercalcemia. The squamous cell cancer causes hypercalcemia. So right, so your answer to this question is squamous cell cancer. Answer is squamous cell cancer. Many of you might wrongly mark it as small cell cancer. But remember one of the exceptions in the paraneoplastic manifestation of lung cancer, and that is squamous cell cancer, right? So next question was again from integrated respiratory system and neurology. You have a patient of ptosis, right? And they are showing a CXR with lung mass. You have a chest x-ray with lung mass, and they have also said that your patient is complaining of sharp pain radiating to upper limb. So this means your patient is having a Pancoast tumor. And the manifestations are due to Horner syndrome. The ptosis is due to the Horner syndrome. Right? Next question was a very important question from neurology. It is basically testing your lot of concepts. So you are asked here that the patient has got injury to the lateral part of the dorsal column in the cervical region, and what will be the manifestations. So if you are aware of the cross section of the spinal cord, you know that there are, mostly we are talking about the two tracts here. One is the spinothalamic tract and the other is the dorsal column. Right? In the spinothalamic tract, you have CTLS. The sacral fibers are towards the outside. But in the dorsal column, the sacral fibers are towards the inside. So this is the first concept that you should be aware of. And what is the second concept that you should be aware of? The second concept is about the tract. These are basically the ascending tracts. Right? So what you need to remember here is the crossing occurs. The crossing occurs at the medulla oblongata. But in spinothalamic tract, The crossing is occurring at spinal cord. For the spinothalamic tract, you have the crossing at spinal cord level itself. Whereas for the dorsal column, they are crossing at medulla, brainstem. They are crossing at medulla. So this is an important concept to decide whether you will have ipsilateral manifestation or you will have contralateral manifestation. So this is the second concept which you should be aware of. Now going to this question, now you are aware of the two concepts. So if we apply the first concept, we'll be sure about the fact and we will zero down to the two options, that either it would be ipsilateral leg or it would be contralateral leg, because it is affecting the cervical cord, and as we know that the medial most fibers are the sacral fibers. The medial most fibers are the sacral fibers. So your leg would be affected. Now if we apply the second concept, where the dorsal column pathways are basically crossing at the medulla. Unlike the spinal cord, unlike the spinothalamic tract which crosses at the spinal cord, they are basically crossing at the level of the medulla. So that's why in the Brown-Sequard syndrome, you have the contralateral involvement of the spinothalamic tract. So applying that same concept, your answer here would be proprioceptive loss at ipsilateral leg. The proprioceptive loss will be seen at the ipsilateral leg. So that is the answer, and I'm sure you are aware of this concept which I have explained. So this was a very good question that was asked from the neurology part, right? So a next question that was asked, that there is a presence of spike and dome pattern. A spike and dome pattern is seen in the kidney biopsy. A spike and dome pattern is seen in the kidney biopsy, and you were asked about which of the infective etiology was seen. I mean, that was the options that I could collect from the students, that they were asking you about the infective etiology. So if you are asked about the infective etiology and if Hep B was given in the option, then Hep B would be answer. But let me tell you, the spike and dome pattern is basically seen in membranous nephropathy. It is seen in membranous nephropathy. So the type of glomerulonephritis that we have discussed about so many type of glomerulonephritis and the nephrotic syndrome, the nephritic and the nephrotic syndromes. And in the nephrotic syndrome, we have the discussed about FSGS and membranous nephropathy. So membranous nephropathy on kidney biopsy, they show the spike and dome pattern, right? And although malignancies are very common with membranous nephropathy, but infective agents are also responsible for membranous nephropathy, and one of them is Hep B and one of them is Hep B. So if they had asked you about which type of nephrotic syndrome is associated, then your answer would be membranous nephropathy, and if the infective agent was given in the option, then the answer would be Hep B, right? Next question was basically, you have a patient with lung fibrosis and hypothyroidism. So a patient with lung fibrosis and hypothyroidism, and your drug was asked, and amiodarone was one of the options. So let me tell you that amiodarone is basically responsible for, it can cause both hypothyroidism and hyperthyroidism. It can cause both hypo and hyperthyroidism. In hyperthyroidism, you have two types of thyrotoxicosis. One is AIT type 1 and AIT type 2. So this is about the thyroid abnormalities that you see with amiodarone. Along with that, you can have pulmonary fibrosis. And you can have peripheral neuropathy also. With amiodarone, right? So this was the integrated pharma and medicine question. Okay. Next question was asked, you are having diarrhea, dermatitis and dementia. So you are very much aware of the fact that you see this in niacin deficiency. And it's a very common PYQ that has been asked. So nothing more from this area basically. This was a image based question. So if you had followed my INICET recall videos, so in INICET recall videos I have told you that this question was asked. So this is basically a case of subdural hemorrhage. This is basically a case of subdural hemorrhage. You can see that there is a concavo-convex. You can see that there is a blood which is basically having a concavo-convex boundary. It's having a concavo-convex boundary and is basically due to the rupture of the bridging veins. And it is basically due to the rupture of the bridging veins. Had it been a EDH, you would have got a convex structure. You would have got a convex structure. So this was asked in INICET. Also, this was asked in FMG also. And this has been repeated in NEET PG also. So consecutive 3 exams, you got this question, right? A next question that was asked, you have a patient who is having a tingling and loss of sensation in the lateral 3.5 digits. Lateral 3.5 digits. So basically you have the symptoms in the distribution of the median nerve. You have basically symptoms in the distribution of median nerve. Now what are the tests that we have in the diagnosis for the median nerve? You can do the Fallon's test. You can do the Tinel's. You can have reverse Fallon. And you can have a Durkin test. You can have a Durkin test where basically you do the carpal compression test. It's basically a carpal compression test. So your answer here would be carpal tunnel and Durkin test. Your answer would be carpal tunnel and Durkin test. This question was basically your integrated microbiology and medicine question. They're asking you have a HRP2 enzyme detects which Plasmodium species. So it's a one-liner question. It has been designed for detecting Plasmodium falciparum. This test is basically designed for detecting the Plasmodium falciparum, right? Gout. Another important topic, guys, is gout. You are getting a lot of questions from gout. In FMG, there were around 3 questions from gout. And in NEET PG also, it did not disappoint. You had around 2 questions from gout. So they are asking you which drug is responsible for decreasing the production of uric acid. They are responsible for decreasing the production of uric acid. I guess apart from colchicine, allopurinol, other options were, I think, diclofenac. And the other option, from wherever I recollected, they could not say. But anyways, the answer here would be allopurinol. The answer here is allopurinol. So a xanthine oxidase inhibitor. You have drugs like allopurinol, febuxostat, right? So these are the drugs basically that decrease the production of uric acid, and it is not used in acute gout. Remember this fact. It is not used in acute gout, otherwise it will precipitate acute gout. It is not used. Next question was, you have a patient who's having hematemesis, melena, and in the background the patient is having alcohol intake and there is a history of aspirin. So you have a history of NSAIDs. And the patient is having a upper GI bleed. So that makes it very likely that your patient is having a peptic ulcer disease due to the use of NSAIDs. Had it been an alcoholic binge, and then followed by copious vomiting, then you might have thought of Mallory Weiss tear or something like that. But here they are giving a history of intake of aspirin, and there is no such history of retching and other things that would make you think of Mallory Weiss tear or not. So your answer here would be peptic ulcer disease. Right? Next question that we're asking is, you have a sudden onset chest pain. There is a sudden onset chest pain, right? Along with that, there is radiation of pain. There is radiation of pain to interscapular area. And the other important thing that you can make out from this question is there is difference in BP. There is difference in BP that has been recorded between the two arms. There has been a difference in BP that has been recorded in two arms. So acute onset chest pain along with this features make the diagnosis aortic dissection. So this is basically a case of aortic dissection, right? Okay. Next question that has been asked, another question from neurology. You have a 40-year-old man who is having a UMN paralysis of lower limb, right? So a UMN feature of lower limbs that could be in the form of increased reflexes, and there was absent ankle reflex. So whenever you have got UMN features and with absent ankle reflexes, you should think of SACD. You should think of SACD where there is vitamin B12 deficiency. There are other conditions also that can simulate SACD, which is vitamin E deficiency, hypocupric myelopathy, right? Hypocupric myelopathy. In ALS and in MS, you will not have absent ankle reflex usually. You will have exaggerated jerks all over the body, right? ALS has got presence of both UMN plus LMN. Right? And MS has got other features other than the UMN and the LMN lesion. It can have sensory, it can have bladder involvement, it can have optic neuritis. There can be UMN features, right? There can be UMN features in the form of increased reflexes and extensor plantar response. So your single best option in this question is SACD, right? Next question is, this is also a repeat question that you often get in FMG and NEET PG papers. They are now regularly asking you questions from the environmental medicine. So here you have a farmer who has collapsed in summer heat, and they are asking you which of the following is least likely to occur. So they had also mentioned that there is a decreased skin turgor. So basically they are implying here that the patient has had heat stroke. So when there is a heat stroke, the temperature rises. Along with that, there is tachycardia, hypotension, right? Some textbook they mention that you might have sweating, but a classical heat stroke, what we have read is, and what we have been reading is, classical heat stroke, they have absence of sweating. So red and hot we see because the temperature is raised. Tachycardia is definitely there. Hypotension is there because of the dehydration. What you have is absence of sweating. In heat stroke. Right? So your answer is sweating. Right? Next question, another question. They are asking from rheumatology. So you have an alcoholic patient. So you know one of the trigger that the patient is taking alcohol. And there is a painful and swollen first MTP joint. So first MTP joint, usually we think of gout. And they have also mentioned that it is painful and swollen. So whenever we are talking about disease that is involving of first MTP joint, our first diagnosis that should come to our mind is gout. And why they have mentioned alcoholic is because alcohol is one of the triggers of acute gout. Right? And when you do a synovial fluid analysis in a patient of gout, what you will get is negative birefringent crystals, along with that you will have increased TLC, right? So your answer is gout. a next question that they had asked is a drug that inhibits both ACE and neprilysin inhibitor. A drug that inhibits both ACE and neprilysin inhibitor. So you have to remember that this is one of the drug which among the other group of the same drugs that we have, that is the ACE inhibitors, ARB blockers, and the new group of drugs that we have ARNI, these drugs has got the maximum potency to cause increased bradykinin levels, and hence the angioedemas. So you did not have any option of ARNI in your question. So your answer is omapatrilat, right? It is a drug that inhibits both ACE as well as the neprilysin, right? So your answer would be omapatrilat. Okay. Next question is an integrated medicine and derma question, that you have a HIV positive patient, whose CD4 count is less than 100, and with this rash that I have mentioned, and they have already mentioned that it is a pearly white nodules with umbilication, central umbilication. So whenever they are mentioning about this thing, you should remember that your answer is molluscum contagiosum. Right? Okay. So next question. So a 10-year-old child who has got a history of pyoderma. So क्या मिल रहा है अपने को यहाँ पे? स्किन इन्फेक्शन की एक हिस्ट्री है. There is a history of skin infection, followed by the patient is having a cola colored urine, hematuria, and there is an increased creatinine. So if you were asked about the cause, this is a case of post-streptococcal glomerulonephritis. Now, if you are asked about the pathology, then the pathology is basically crescent formation, because this has landed into rapidly progressive glomerulonephritis. So answer here would be crescent formation. Right? Next, this is basically a repeat question. One of these questions was asked in the recent FMG examination also. Here they are asking you that a patient on chemo has developed decreased platelet count. Which drug will you use to increase the counts? Answer is basically oprelvekin. Right? This is the drug that we use to increase the platelet count in the chemo group of patients, right? So this was just a simple one-liner that was asked. Now, next important question that was asked is from thyrotoxicosis. So you had a similar kind of image in your exam, where they are showing you that the patient is having a ophthalmopathy, and the options that they have given you, it clearly showing that the patient is having thyroid eye disease, which you most often see in Graves' disease. Now, what are the antibodies that you can see in Graves? Antibodies you can see is thyroid stimulating immunoglobulin, and you can also see thyroid receptor antibody. So this is definitely not the answer. But you should also remember here that if you are not aware of the fact that anti-TPO antibody can also be seen in the Graves' disease. Normally we consider anti-TPO antibody to be seen in Hashimoto. Normally that's what we remember. But you should also remember that in close to 80% of Graves, this can have anti-TPO antibody. So if a question would have been framed in such a way that thyroid receptor antibody was not mentioned in the question, then this question would have become a difficult one. because many of us, we are not aware of the fact that even Graves' disease can have anti-TPO antibody, and it is seen in a maximum chunk of patients also. 80% is a good chunk of patient. But since they have mentioned thyroid receptor antibody, so your answer to this question would be thyroid receptor antibody. Your answer would be thyroid receptor antibody. But a take-home message from this question is anti-TPO antibody can also be seen in Hashimoto. Other than Hashimoto thyroiditis, can also be seen in Graves' disease, right? Next question was asked, you have a patient on dialysis. Just after dialysis, patient develops headache, nausea and vomiting. So this is basically a case of dialysis disequilibrium syndrome. It is a case of dialysis disequilibrium syndrome. Normally we see this after the first dialysis. Normally we see this after first dialysis, where there is development of cerebral edema. Where there is development of cerebral edema, right? So in dialysis disequilibrium syndrome, to reduce the cerebral edema would form the cornerstone of the management. And which of the following drugs that have been mentioned can be used for decreasing the cerebral edema? The answer here would be mannitol. The answer would be mannitol. Okay. Next question was a repeat question which I think everyone must be expecting. You have a petechial rash and the owl's eye appearance. Whenever you are getting this question where they are asking you about owl's eye appearance, the answer would be CMV. The answer would be CMV, right? So this basically brings us to the end of the discussion about the different recall based questions that I could collect from my students and different online sources about the medicine paper that we had today. And if you have any doubts, if you have any questions, you can comment in the chat box below. So my take home messages and analysis of the paper was, now the pattern is now shifting to an integrated question. The pattern is now shifting to the integrated questions. You're getting integrated questions of pharma, medicine together. You are getting integrated question of ophthal, neuro together, integrated question of anatomy and medicine together. So no more direct questions and a very less number of direct questions. Too much emphasis on neuro. And what you need to also remember that whenever you are sitting for the next paper, you're preparing for the next paper, make sure that you revise the papers that have been asked before. Like they were most like the previous FMG paper that just happened, that had got questions from gout, 2 questions from gout, and almost similar questions had been repeated in NEET PG just after the FMG examination, right? In the FMG examination, you had a question on the optic pathway. So you got a question of optic pathway in the NEET PG paper